Okay, so I will be continuing our topics. I will do acute medicine shock, then I'll do um, rheumatic fever, infective endocarditis, and nutrition, and of course, hormones. So, yeah, let's just get started. Um, Shock is a state of cellular and tissue hypoxia with circulatory failure and poor perfusion. Hypovolemic shock is reduction in total blood volume due to hemorrhage, wounds, and vomiting and diarrhea. Cardiac shock is due to MI, carditis, pulmonary embolism, drug-induced cardiac tamponade, and because of arrhythmias. So septic shock is bacterial infection with release of toxins into the circulatory system. Neurogenic or visceral shock is sudden anxious stimuli causing spastic vasodilation. Patient goes into cardiac arrest or recovers spontaneously. Spinal cord injury or anesthesia can cause neurogenic shock. Anaphylactic shock is type 1 hypersensitivity reaction. Respiratory causes you have atelectasis, thoracic injury, and tension pneumothorax. Other causes you have adrenal insufficiency like Addison's disease and mixed edema. So, pathophysiology. So, any cause of shock, low cardiac output decreases the renal blood flow, decreases GFR, leading to decreased urine output. It is lead to activation of RAS and angiotensin 2 and aldosterone mediated vasoconstriction and saltwater retention, respectively. ADH is released, further retention of water is seen. Persistence of shock, further decrease in cardiac output is seen. Hypoxia and anaerobic metabolism is there. Lactic acidosis, cell wall damage, sodium and calcium enters the cell, potassium leaks out of the cell, hypercalcemia, hyponatremia, hypocalcemia will be seen, and intracellular lysosomal breakdown leading to release of proteolytic enzymes will occur in the last minute. Then you have sickle cell syndrome, case of sickle cell anemia, and then SIRS you have due to vasodilation there is increased vascular permeability. DIC, and sickle cell syndrome. You have multi-organ dysfunction which leads to kidneys, liver, and brain in irreversible shock. So the effects of shock on heart, you have low cardiac output, hypotension, and reflex tachycardia. Persistent shock, you have hypoxia, release of cardiac depressants leading to cardiac failure. Hypoxia leading to cardiac depression and cardiac failure. So in lungs, you have interstitial edema leading to decreased gas exchange, tachypnea, and acute respiratory distress syndrome. Then you have metabolic, you have hypoxia induced lactic acidosis and antidiuretic hormone water retention. Cellular changes, you have lysosomal enzyme mediated destruction of cell like sickle cell syndrome. Brain, you have decreased brain perfusion leads to loss of consciousness. Brain is the last organ to get underperfused in the shock. Kidney, you have decreased GFR leading to decreased urine output, increased RAS mediated salt and water retention. Blood, you have disseminated intravascular coagulation due to consumption coagulopathy leading to internal bleeding. So investigation, you monitor BP, heart, pulse rate, respiratory rate, urine output, central venous pressure, and cardiopulmonary capillary wedge pressure. We estimate pH, serum lactate level, blood urea, creatinine, prothrombin time, activated partial prothrombin time, and arterial blood gas analysis you have to perform. So treatment, you have acute critical stage management, A, B, and C, CAB, circulation A and B, fluid replacement, you give lingual adnut, Hartmann solution, plasma expander, hematocell, and blood transfusion. Anotropic agents, you have epinephrine, norepinephrine, dobutamine for cardiogenic shock. So epinephrine for anaphylactic shock, and norepinephrine for vasodilator septic shock, and dobutamine for cardiogenic shock. So acidosis, you give IV sodium bicarbonate. Steroid hydrocortisone improves perfusion and decrease inflammatory effect. So pain control, you give morphine. Ventilator and ICU care management is done. MASD, military anti-shock trouser you can provide. Circumferential external pressure of 40 mm of Hg. Lower limb and abdomen, it redistributes blood towards the center. Then we give septic shock, widespread inflammation and infection and toxic release, and dangerously low pressure pathogenesis, um, toxins from bacteria, fungi, virus, and parasite. Inflammation, activation of macrophages, neutrophil, and monocytes. It releases cytokinins and free radicals. SIRS is septic chemotaxis, endothelial injury, and altered coagulation state. Sepsis induced multiple organ septic induced. One second, I'll just check out what SIRS is. Systemic inflammatory response syndrome. And another thing, blood constituents. I mean, looks like I have no severe systemic inflammatory response syndrome, which is chemotaxis, endothelial injury, and altered coagulation state. So you have reversible hyperdynamic state also, fever, tachycardia, and tachypnea, severe circulatory failure with MODS, failure of lung, liver, kidney, heart with disseminated intravascular coagulation, irreversible hypodynamic cold stage of septic shock also will be finally last. Reversible, so you have toxins released, inflammatory activation, then release of cytokinins and free radicals, SIRS, reversible hyperdynamic state, fever, tachycardia, and tachypnea, severe circulatory failure with multiple organ dysfunction syndrome, failure of lung, liver, kidney, heart with disseminated intravascular coagulation, finally lead to irreversible hypodynamic cold stage of shock. So stages of septic shock: hypodynamic, cold stage; hyperdynamic, reversible stage, tachycardia, tachypnea, fever, pyogenic response is intact; hyperdynamic, hypovolemic, pyogenic response is lost, patient in decompensated state; and irreversible shock leading to multiple organ dysfunction syndrome. Treatment is correction of fluid and electrolyte, blood transfusion, immediate perfusion is most important, appropriate antibiotics you have to provide, treatment of underlying cause, drainage of abscess, nephrotomy for peritonitis, resection of gangrenous bone, wound excision. Norepinephrine, drug of choice for septic shock, and high dose steroid therapy for contraindicating toxemia. Then you have anaphylactic shock, severe type 1 it is histamine, serotonin, something else, I don't know. Basically allergic reaction due to type 1 allergic reaction. Sensitivity, I forgot. Okay, exposure to allergen, primary sensitization, IgE ghost mast cell, subsequent allergen exposure leads to secondary sensitization, release of anaphylactic mediators from mast cell. Anaphylactic mediators are histamine, heparin, serotonin, leukotrienes, prostaglandins, ECFA, and NCF, and platelet activating factors. So causes of anaphylactic shock: you have drugs, biological agents, proteins, and insect bites. In drugs you have penicillin, cephalosporin, tetracycline, sulfametazole, vancomycin, diuretics, and beta blockers. And biological agent you have blood and its components, tetanus antitoxin, rabies antitoxin, diphtheria antitoxin, and vaccines, proteins, peanut, fish, stuff like that. And bee wasps. And bee wasps you can give drugs you can take right randomly. Biological agents, blood, tetanus. Okay. Clinical features: mucocutaneous, pruritus, flushing, urticaria, angioedema, conjunctival injection, gastrointestinal nausea, vomiting, abdominal gas, diarrhea, breathing, respiratory, bronchospasm, dyspnea, wheeze, laryngeal edema, stridor, and pulmonary edema, cardiovascular, tachycardia, hypotension, arrhythmia, syncope. Treatment: you provide epinephrine 0.5 ml of 1 in 1000 intramuscular. IV also can give 1 in million. over 2 to 10 minutes. Oxygen you give endotracheal intubation, tracheostomy, intermittent positive pressure ventilation. Hypotension you give fluids and dopamine. Bronchodilators you give nebulized salbutamol. Hydrocortisone 200 mg you give for persistent bronchospasm. Diphenhydramine and ranitidine. Agitation blocker you give. Then syncope. Syncope is transient loss of consciousness due to inadequate cerebral flow due to secondary abrupt decrease in cardiac output. If syncope lasts for 5 minutes, it is dizziness, 10 minutes unconsciousness, 15 minutes is convulsions. Okay, so cardiac you can have extreme bradycardia, heart block, SVT, aortic stenosis, HOCM, arterial tumors, pulmonary stenosis, hyperpulmonary hypertension, pulmonary embolism. Drugs you have antihypertensive, beta blockers, and vasodilators, hypovolemia, hemorrhage, fluid loss, and diabetic precoma. Reflexes you have esophageal syncope, osteostatic hypotension, hypersensitivity, carotid sinus, tussive shock syndrome, syncope, and micturition syncope. Deglutition syncope also you can have. Defecation syncope also finally. Then delirium. Delirium is a ERDS, mechanical ventilation. Okay, this is topic suggestion. Okay, delirium is acute confusion state characterized by a period of agitation, heightened mental activity, increased wakefulness, hallucination, motor hyperactivity, autonomic stimulation, impairment of attention. It is caused by head injury, cardiovascular accident, cerebral infarction, epilepsy, hypoglycemia, diabetic ketoacidosis, hypoxia, renal or hepatic failure, electrolyte or acid base imbalance, Wernicke's encephalopathy, septicemia, SBE, heat stroke, hypothermia, toxins, alcohol, barbiturates, narcotics withdrawal, acute mania, schizophrenia, and hysteria. It is all these causes. It is having agitation, heightened mental activity, increased wakefulness, hallucinations, motor hyperactivity, autonomic stimulation, impairment of attention. Then you have alcohol withdrawal for delirium tremors, and visual hallucinations. Okay, moving on to acute respiratory system. It is acute lung injury characterized by increased permeability of alveolar and capillary membrane and pulmonary edema. Etiology has sepsis, trauma, disseminated intravascular coagulation, drug overdose, inhalation of toxin, Goodpasture syndrome, SLE, drowning, and period after bypass surgery. They will have acute respiratory distress. It consists of 3 phases: exudative, proliferative, fibrotic. Clinical features: severe hypoxemia, decreased pulmonary compliance, dyspnea, increased respiratory rate, and diffuse rales and bronchi. Evaluation: you have diffuse interstitial or alveolar infiltrates. At your blood gas analysis, you have decreased PaO2, increased PaCO2, Swan-Gotter catheter. You have normal cardiac output, normal capillary wedge pressure, and increased pulmonary artery pressure treatment. Normal cardiac output, normal cardiac capillary wedge pressure, increased pulmonary artery pressure treatment. Treatment you have treatment of the underlying disorder, mechanical support you give, positive and expiratory pressure, nitric oxide inhalation, which reduces the pulmonary artery pressure and improves oxygenation. Mechanical ventilation, mechanical support to ventilatory function of respirator and improve oxygen by positive pressure. Indication for mechanical ventilation: you have respiratory rate more than 35 per minute, inspiratory force less than 12 cm of H2O, vital capacity is less than 10 to 15 ml per kg, PaO2 is less than 360 and FiO2 is more than 60%, PA carbon dioxide more than 50 mmHg, pH is less than 7.35. You have absent gag or cough reflex. Mode of ventilation: you have control mode, assist mode, control mode ventilation, synchronized intermittent mandatory ventilation, SIMV, pressure support ventilation, positive airway CPAP, positive end expiratory pressure PEP, inversion ratio ventilation, and non-invasive mechanical ventilation. Contraindications: you have respiratory arrest, cardiovascular instability, high aspiration risk, viscous or copious secretion, craniofacial trauma, and extreme obesity. Complication: asthma, pneumonia, tracheal stenosis, and barotrauma. Air embolism, subcutaneous emphysema, pneumopericardium, pneumoperitoneum, pneumomyasthenium, and pneumothorax. Wherever air will be there, air is going in other places, tracheal stenosis will be there, stenosis of the trachea will be there, and pneumonia will be there, and aspiration will be there. Complication contraindicated in case of respiratory arrest. Breathing only is not happening. Cardiovascular instability, arrhythmia, high aspiration risk, copious secretion if there is there, craniofacial trauma, and extreme obesity. Respiratory rate more than 35 per minute. Inspiratory force less than 25 centimeter of water. Vital capacity is very less. Partial pressure of oxygen less than 60 mm. Partial pressure of carbon dioxide more than 50 mm. pH less than 7.5. FiO2 more than 60. Absent gag or cough reflex. Okay, so coming back, I will come back to this. Let's do 64 endocrinology. So endocrinology is my worst subject by far. I fucking hate everything in endocrinology. Let me just do this properly, then I'll go back to cardiovascular system, mitral stenosis, mitral regurgitation and all. Then finally respiratory. I have obesity to do and nutrition I'll do off. Then I'll do obesity. SLE I'll do once. Dyslipidemia I want to check once. Somewhere I'll do in PPT. Management of dyslipidemia and fat globulins, cholesterol chelating agents and stuff like that. You have nothing I have to do. Okay. Yeah, fine. First you have thyroid. Amiodarone induced thyroid dysfunction. You have thyrotoxicosis, you stop amiodarone and treat with antithyroid drug, and hypothyroidism, you continue amiodarone and replace L-toxin, thyroxide sodium. So thyrotoxicosis is a state of excessive thyroid hormone. Hyperthyroidism is state of excessive thyroid gland function. Thyroid storm or crisis is deterioration of thyroiditis with hyperpyrexia, tachycardia, high cardiac output. high output cardiac failure. So it's caused by Graves' disease, most common. TSI binds to TSH receptors, increase synthesis of T hormones, multinodular goiter, Plummer's disease, solitary thyroid nodule, thyrotoxicosis. You have viral autoimmune post-radiation, thyrotoxicosis factita, which is surreptitious T4 consumption, especially in female health workers. God damn it. Every time when I come to hormones, man. Fuck. Okay. Thyrotoxis. Thyrotoxicosis. So, Graves' disease, most common. Autoimmune TSH binds to TSH receptors, increasing synthesis of T hormones. At autoimmune TSI, thyroid stimulate thyroid binding immunoglobulin against thyroid receptors. They bind to thyroid receptor, increase synthesis of the hormones. Multinodular goiter, you have Plummer disease. Solitary thyroid nodule may be there. Thyroiditis may be autoimmune, viral, or post radiation. Thyroid factita, which is serendipitous T4 consumption, especially by female health workers. Exogenous iodine consumption. Then you have drugs amiodarone, TSH stimulating tumors, primary tumors. Amiodarone was told here also induces thyroid dysfunction. Stop with, treat with anti-thyroid drugs. 1 second, I'll just check out amiodarone uses. I think it's used in arrhythmias, but I want to just check. Ventricular arrhythmias. Okay. Continuing. You have HCG producing tumors and stroma ovarian teratoma. So clinical features, you have symptoms. Teratoma means every other places, every single type of cells are coming. So it will produce this thing, TSH. And HCG has the ability to mimic T3, T4 and all. Therefore, it is producing HCG producing tumor also increases T4. So symptoms, you have nervousness, irritability, increased perspiration, easy fatigue, irritability and tremor, heat intolerance, weight loss, and despite increased appetite, tachycardia, insomnia, hyperdefecation, constipation also, and constipation is more than diarrhea, muscle weaknesses, palpitation, angina, congestive heart failure, dementia, delirium, depression, amenorrhea, oligomenorrhea, male impotence and loss and libido. It's all increased perspiration, increased nervousness, increased fear, tremor, heat intolerance. Heat also increased. You cannot intolerate. Weight loss will be there, even though appetite is increased. Metabolism is very much increased. Tachycardia will be there. Insomnia, constipation, diarrhea, fibrillation. Okay, stuff like that. So signs here: skin is warm and moist due to vasodilation. Palms are warm, moist, hyperemic. Plumber's nail, retraction of nail from the bed is seen. Pre-tibial myxedema, which is mucopolysaccharide accumulation due to. So alopecia, brisk deep tendon reflexes. Vitiligo, you have marker for autoimmune etiology. Thyroid brute, which is heard over the line due to increased blood flow. So eye signs, you have one graphis, which is lid lag. Joffrey's, which is absence of wrinkling of forehead on upgrades. Stelvax, which is decreased frequency of blinking. Darylmetace, which is slit retraction exposing upper sclera. Mobius is absence of convergence. So grading of eye changes, you have no specs, no eye changes, only eye signs. So 1, 2, 3, 4, 5, 6, 7. So you have NO, only signs in upper lid, soft tissue impairment, proptosis, extraarticular muscle involvement, corneal involvement, SPES, CS, slight loss due to optic nerve involvement. So investigations, you have serum markers, T3 and T4 will be elevated, TSH will be decreased. Antibody detection, you have TSH immunoglobulin, thyroid stimulating immunoglobulin. If TSI is there, then it is Graves' disease. TSH receptor antibody, you have Graves' disease. Antimicrosomal antiperoxidase antibody, you have Graves' disease and Hashimoto thyroiditis. Radioiodine uptake, I-131, you have differentiate between high and low uptake hyperthyroidism. So high radioactive iodine uptake and low radioactive iodine uptake. High is in Graves' disease, toxic multinodular goiter, toxic adenoma, hashitoxicosis, TSH secreting pituitary tumor, choriocarcinoma, iridiform mole. And low radioactive iodine uptake is seen in subacute thyroiditis, painless thyroiditis, iodine-induced hyperthyroidism, thyroid hormone therapy, and stroma ovary. I is basically Graves, toxic nodular adenoma, like all hashitoxicosis, tumors, all types of tumors is high. Low is subacute thyroiditis, painless thyroiditis, iodine-induced hyperthyroidism, hormone therapy, and stroma ovary. All of these are low radioactive iodine uptake. So treatment, beta blocker for management of palpitation, tremors, anxiety, tachycardia, and sweating. Before that, serum T3 and T4 will be increased, TSH will be decreased, because this will be keeping on increasing. This will auto like regulation, it will be decreasing, but still this will be increasing. TSI, TSH receptor antibody, antiperoxidase antibody. As you go to thyroid is also rapid radioiodine uptake, and eye changes, you have no specs. From behind you are coming front, upper eyelid, first soft tissue, then extraarticular, then proptosis, extraarticular, corneal involvement, slight sight loss only will sight only will go off. Okay, that was hyperthyroidism. Next we move on. Okay, wait. So treatment, you have beta blockers for the acute management. Thionamides, carbimazole, methimazole, propylthiouracil inhibit thyroid hormone synthesis. It also inhibits peripheral conversion of T4 to T3. Side effects is agranulocytosis, rash, arthralgias, and nephrotoxicities. Carbimazole, methimazole, propylthiouracil. Another drug causes granulocytosis. Just a second. Clozapine, anti-inflammatory drugs. Insights, penicillin, chlorphenical, trimethoprim. Okay, fine. Exophthalmos, you have corticosteroids, tarsorafy, and orbital decompression you can do. Atrial fibrillation, you can do cardioversion. Radioiodine 131, you can do destruction. You provide this to cause destruction of thyroid follicular cell. Main complication is hypothyroidism, contraindicated in pregnancy and breastfeeding due to risk of cretinism. Okay, then hypothyroidism in non-pregnant, you give atenolol, methimazole, 15 mg, 25 mg. In pregnant, you give atenolol, propylthiouracil, however, and radiothyroidine is contraindicated because it leads to cretinism. Then thyrotoxic crisis. This is one of the most important piece of shit. You give propranolol 80 mg every 6 hours orally. Potassium hydrate 60 mg, which reduces the T3 level to normal in 48 to 72 hours. Carbimazole 60 to 120 mg, which inhibits synthesis of new thyroid hormones. Injection dexamethasone 2 mg IV 6 hourly, and you give fluid replacement. Then you have a medication for thyroid hormone. So thyroid hormone T4, T3, thyronin. So you have thyroid inhibitors. There are some which inhibit hormone synthesis, like antithyroid drugs. They are like propylthiouracil, methimazole, carbimazole. Then you have inhibit iodine trapping, like ionic inhibitors like thiocyanates, HCl, perchlorates, CiO4, and nitrates, NO3. There are some which inhibit hormone release, like iodine, iodides of sodium and potassium, organic iodide. There are some which destroy the thyroid tissue, like radioactive iodine, I-131. Iodides, sodium, this thing. Okay. Then hypothyroidism, which is insufficient synthesis of thyroid hormone. Cretinism in hypothyroidism since birth. Mixed edema is severe hypothyroidism with accumulation of hydrophilic mucopolysaccharide in skin and other tissues. Subclinical hypothyroidism is increased TSH, but T3 and T4 remains constant. Seen after partial thyroidectomy or I-131 therapy. Then you have mixed edema coma, which is a state of hypothermia. Body's temperature is less than 25 degrees Celsius. Hypotension, convulsions, hypoglycemia, hypoventilation, and coma. Then it is precipitated by cold, sepsis, surgery, CNS depressant drugs, pneumonia, congestive cardiac failure, myocardial infarction, and gastrointestinal bleeding. So types you have congenital hypothyroidism, reversible, irreversible. T4 is essential for development of CNS. Acquired hypothyroidism, where the effects are reversible. So causes of both, you have primary hypothyroidism, Hashimoto, autoimmune, and chronic lymphocytic thyroiditis, most common cause. Iatrogenic is prior hyperthyroidism, radiotherapy, thyroidectomy, and medications. Secondary hypothyroidism, which is pituitary disease. You have tertiary hypothyroidism, which is hypothalamic disease. Pituitary, like Sheehan syndrome and deficiency of TSH, deficiency of TRH in tertiary hypothyroidism. So differentiation between primary and secondary. Skin will be coarse, hair will be soft and silky, BP will be hypertensive, secondary will be hypotensive, menstruation will be menorrhagia, secondary will be amenorrhea, cardiac diameter will be increased, it will be decreased in secondary, serum TSH level will be increased in primary. It will be decreased in secondary. Because there is decreased amount of T4 and T3, it will be increased in primary, but it will be decreased in secondary, because that is normally only decreased. Serum cholesterol will be increased, it will not be altered in secondary. Deficiency of other pituitary hormone will be absent, and it will be present in secondary. Other pituitary hormones also will be affected. Cholecystokinin, calcitonin, my man. decreased BP, everything will be decreased here. Hypotension, convulsions, hypoglycemia, hypoventilation, coma. Precipitated by cold, sepsis, surgery, CNS depressant drugs, pneumonia, CCF, MI, GIPD. Okay, moving on. So, congenital hypothyroidism, clinical features. There will be symptoms of lethargy, somnolence, constipation, poor feeding or suckling, delayed dentition, and mental retardation. Then, signs, you have dry, cool, mottled skin, hoarse cry, puffy face, broad nose, flat nose, broad, flat nose, large protruding tongue, abdominal will be protuberant, umbilical hernia will be there, and skull there will be large posterior frontal eye. So investigations, you have cord blood, T4 and TSH, serum T40 TSH, radioactive iodine uptake, X-ray. You can do knee, upper femoral, upper tibial epiphysis will be absent, lower femoral, upper tibial epiphysis will be absent, foot cuboidal epiphysis will be absent, and skull you have stella size, super stella classification. You have large posterior frontal umbilical hernia, protuberant abdomen, puffy face, solemnness, lethargy, constipation, poor feeding, delayed dentition, mental retardation, stuff like that. Okay, then moving on. Acquired hyperthyroidism, clinical features, you have juvenile is short stature, upper segment is more than lower segment, delayed dentation. Poor performance at school will be there. Delayed sexual maturation will be there. Costner Debre Simaligui syndrome, which is generalized muscular pseudohypertrophy, will be there. In juvenile, short stature, delayed dentation, poor performance, delayed sexual maturity. In adults, you'll be having solemnness, lethargy, tiredness, weight gain, poor appetite, cold intolerance, skin cold, coarse, dry and flaky. Same thing. Dry, cool, moderate skin, dry, cool, flaky skin. Neurological, you have memory impairment, depression, eighth nerve deafness will be there. Carpal tunnel syndrome will be there. Sensory ataxia and cerebellar ataxia will be there. So there's like 5% charge in my Apple pen. So let's see if I can finish it off before the charge goes off. If I cannot, then I will change the topic. I will go to cardiovascular system. I will teach infective endocarditis, atrial fibrillation, atrial septal defect, ventricular septal defect, patent ductus arteriosus. Those 3 topics I'll do. And then I'll do triglyceridemia and obesity, nutrition. Both of them I have to do. I'll do them. Okay. Yeah, but this thing is the main part. Color, there will be yellow or pallor or yellowish due to caroteninemia. Hair will be sparse, brittle. Loss of eyebrows will be there. Skeletal, short stature. Eye will be yellow sclera. Neurological, they will be having acute encephalopathy. Cardiovascular, you have bradycardia, diastolic hypertension, increased peripheral vascular resistance. Cardiomegaly will be there. Pericardial effusion will be there. Increased size, bradycardia, diastolic hypertension, increased peripheral vascular disorder. Okay. Keratonemia will be there. Sparse protein, short stature, yellow sclera will be there. Carpal tunnel syndrome, eighth nerve deafness, sensory ataxia, cerebellar ataxia, depression, memory impairment, acute encephalopathy. Cardiovascular, you have bradycardia, diastolic hypertension, increased PVR, cardiomegaly and pericardial effusion. Muscular, you have pain, stiffness and cramps, muscle weakness, hypotonia, pseudomyotonic reflex, you have deep tendon reflexes, Hoffman syndrome, you have proximal muscle weakness and calf muscle hypertrophy, pain, stiffness, cramps, muscle weakness, hypotonia, pseudomyotonic reflex, Hoffman syndrome, proximal muscle weakness, and calf muscle hypertrophy. Gastrointestinal, you have microclosia, GIT hypomotility, decreased motility of the GIT, ascites will be there, achlorhydria will be there. Metabolic, you have hypothermia, hypercholesterolemia, in the reduced insulin requirement, reduced basal metabolic rate. So then respiratory, you have vocal cord edema, mucopolysaccharide accumulation leading to low pitch and hoarse voice. You have pleural effusion and respiratory muscle weakness. Reproductive, you have female menorrhagia, amenorrhea, infertility and abortion. In male, you have impotence and scrotal effusion. So investigations you can do serum TSH level, which is high in primary hypothyroidism, low in secondary hypothyroidism, which we have taught already. Serum free T4 level will be low, free T4 index, free T4 normal in subclinical cases. Antimicrobial antibody, you have Hashimoto thyroiditis. Serum cholesterol will be having high LDL and low HDL. ECG, bradycardia and T-wave flattening. And echo, you have pericardial effusion. So treatment, you have lifelong HRT, levothyroxine. T4, you provide 100 to 300 microgram per day per oral. Pituitary hypothyroidism, levothyroxine, you have to remember. Pituitary hypothyroidism, you have hydrocortisone replacement initiated before levothyroxine to prevent adrenal crisis. I have to give pituitary hypothyroidism, you have to give hydrocortisone because adrenal crisis may occur. Myxedema, coma, you have L-thyroxine 400 to 500 microgram per IV bolus. L-thyroxine, you have triiodothyronine. T3, hydrocortisone you have to give 8 hourly. Rewarming the patient and ventilatory support, hypoglycemia correction. So again, going back to thyroidism treatment. Propranolol, potassium iodide, carbimazole, dexamethasone, fluid replacement. Beta blockers you give thiazide, carbimazole, methimazole, pentylthyroxine, you give potassium ophthalmos, corticosteroids and all you have to provide. Dexamethasone, atrial fibrillation cardiovascular you can give iodine 131, atenolol, propranolol. Thyroiditis, you have acute seborrheic pathogenic bacterial thyroiditis, Staphylococcus, Streptococcus, and E. coli. Subacute, you have granulomas, viral decurrence, thyroiditis, Coxsackie, adenovirus, mumps, influenza, and Epstein-Barr virus. Lymphocytic, you have painless, silent, and spontaneously resolving lymphocytic thyroiditis. Chronic, you have Hashimoto thyroiditis, chronic lymphocytic, chronic thyroiditis, lymphomatosa, rectal stroma, thyroiditis, inflammatory disorder of non-etiology, gland fibrosis, and PS also will be there. So Hashimoto thyroiditis, you have autoimmune disease associated with HLA DRFI. Clinical features, either features of hypothyroidism or hyperthyroidism, acetotoxicosis, or euthyroid associated with or without goiter. Pressure symptoms will be main. PS. Gland fibrosis, PS. Okay. Riddle's Hashimoto thyroiditis. Hmm. Acute pathogenic bacterial thyroiditis, suppurative, staphylococcus, streptococcus, salmonella, E. coli. Subacute, you have granulomatous. Viral decons, thyroiditis, Coxsackie, adenovirus, mumps, influenza virus. Lymphocytic, you have painless, silent, spontaneously resolving lymphocytic thyroiditis. Okay. Lab diagnosis, you have T3, T4 anti-SS level, auto antibody detection you can do, anti-thyroglobulin antibody, antimicrosomal antibody, and anti-thyroperoxidase antibody. You can do thyroid scan, radioactive iodine uptake, fine needle biopsy. Also, you can do treatment. You have replacement doses in patient with hypothyroidism, euthyroid with goiter, elevated TSH, thyroid hormone treatment. Risk of subsequent hypothyroidism is there. Thyroid hormone treatment is there. You have to give. There may be subsequent hypothyroid. Thyroid hormone replacement. Rapidly enlarging goiter associated with pressure symptoms. Glucocorticoids you have to give. Surgery so that it is relieved. If it is not relieved medically, you can give surgery and remove some parts. Then you have granulomatous viral or dequeron thyroiditis. It's a subacute. Thyroid hormone replacement. Pressure symptoms with or without goiter. Hypothyroidism, hyperthyroidism, or euthyroid. All three can be there. So etiology of granulomatous, you have Coxsackie, adenovirus, mumps, influenza, Epstein-Barr virus. It is associated with HLA BW35. So clinical features, you have unilateral anterior neck pain with radiation to ear or mandible, fever, testicular pain also, fever, malaise, sore throat, dysphagia, symptoms of hyperthyroidism, or tender unilateral enlargement of the gland. Three phases is there: thyrotoxic phase, hypothyroid phase, recovery phase. So lab diagnosis, you have ESR will be elevated, T3 and T4 will be elevated, antimicrosomal anti-thyroglobulin antibody will be negative, radioactive iodine uptake will be decreased because there is disruption of iodine trapping mechanism. Treatment, you have aspirin 600 mg 4th hourly to decrease pain, prednisolone 20 mg 3 times a day, tapered gradually. Symptoms of hyperthyroidism, propranolol 20 to 40 mg per oral TID. Antithyroid drugs are not indicated. Okay. Next, we move on to adrenal insufficiency. You have primary adrenal insufficiency, which is Addison's disease, and secondary adrenal insufficiency. It is due to hypopituitarism, abrupt cessation of exogenous glucocorticoids, which is most common condition. It is inability to release appropriate amount of cortisol, leading to chronic suppression of ACTH by exogenous steroids. You have tertiary adrenal insufficiency and hypothalamic disease. So primary adrenal insufficiency can be idiopathic autoimmune adrenalis, ACTH blocking antibody, ACTH receptor gene mutation. Infectious diseases can be there. Tuberculosis, most common cause of Addison. Fungal, you have cryptomegalovirus, cryptococcus, toxoplasmosis, and pneumocystis. Iatrogenic, you have bilateral adrenalectomy, metastatic disease from lung or breast cancer. Next, clinical features is due to glucocorticoid insufficiency, anorexia, nausea, vomiting, weight loss will be there, diarrhea or constipation will be there, malaise, weakness, acute abdominal pain, hypoglycemia, postural hypertension, all of them can be seen. Due to increased ACTH secretion, you have pigmentation. Low corticosteroid leads to accumulation of ACTH and MSH. Melanocyte stimulating hormone will be increased. Sun exposed area and pressure areas, elbow, knees, palmar crease, knuckles, mucous membranes, conjunctiva, recent scars. All of them will lead to pigmentation. Glucocorticoids, of course, anorexia, weight loss, diabetes, constipation, malaise, weakness, abdominal pain, hypoglycemia, postural hypertension. Okay, so primary you have idiopathic. First of all, ACTH blocking, IgG receptor gene mutation, infections, TB, fungal, cryptococcus, cytomegalovirus, toxoplasmosis, pneumocystis. Iatrogenic is bilateral adrenalectomy if there is tumor, metastatic disease from lung or breast cancer. So you can also have clinical features due to mineralocorticoid insufficiency. You have hypotension, hyperkalemia, increased potassium and decreased BP. Due to loss of adrenal androgen, you have decreased body hair, especially in the females. Hyperpigmentation and hyperkalemia is only seen in hyperadrenalism, not in secondary hypoaldosteronism. So again, these are the clinical features: pallor, coma, postural hypotension, vitiligo, decreased body hair, loss of libido, anorexia, nausea, vomiting, diarrhea, malaise, weakness, hyperpigmentation, neutropenia, lymphocytosis, eosinophilia, hyponatremia, hyperkalemia, hypoglycemia, hypercalcemia. Let's finish it off. So investigations you can do: plasma electrolysis, hyponatremia, hyperkalemia, hypercalcemia will be there. Blood glucose will show hypoglycemia. ACTH stimulation test. So you give synthetic ACTH and blood from serum cortisol or ACTH at 8 am. You give fixed amount, 30 minutes and 60 minutes you check. If it is normal, if it is plasma cortisol is more than 495 nanometer, if it's primary there will be no change, secondary there will be subnormal increase. If you give ACTH in secondary is of course pituitary, ACTH will be not released. So if you give ACTH, it will be increased. Cortisol will be increased. Then you have plasma renin activity. High is plasma insufficiency. Plasma adreno-aldosterone is low. Normally secondary insufficiency, adreno-aldosterone level is normal. Metyrapone test. Confirmed diagnosis: secondary insufficiency. Metyrapone inhibitor of 11B hydroxylase required for cortisol synthesis. Administration leads to fall in cortisol level, rise in ACTH level, rise in 11-deoxy cortisol, immediate precursor of cortisol. Procedure: you give single dose 2 to 3 gram at midnight with a snack. ACTH, cortisol. Okay. So treatment: you have primary adrenal insufficiency, oral glucocorticoid you give daily, prednisone 2 mg in the morning and 2.5 mg in the evening, Hydrocortisone 20 mg in the morning, 10 mg in the evening. Cortisone acetate 25 and 12.5 morning and evening. Then oral fluorocortisone, you give mineralocorticoid daily, which is 0.3 mg with adequate salt intake. Then secondary adrenal insufficiency, you have oral glucocorticoid, you give daily. Mineralocorticoid, the replacement is not necessary. Then you taper steroid gradually. So increased dose of glucocorticoid is needed in obese patient or patients on barbiturates, phenytoin, rifampicin. All of these enhance metabolism of steroid. Steroid doses will be lowered in liver diseases, diabetes mellitus, peptic ulcer, hypertension, old age. So response to replacement, you have appropriate weight gain and regression of pigmentation. Pigmentation will go back to normal. Mm-hmm. 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 That is hypercalcemia, hypercalcemia, acromegaly. If I finish this, then I'm done. Okay. So you give glucocorticoid daily and oral fluorocortisone daily with adequate salt intake. Secondary insufficiency or glucocorticoid, mineral corticoid, taper the steroid gradually. So increased doses, you give glucocorticoid is needed. Obese people, patient on barbiturates, if I'm present because of enhanced metabolism of steroid. Then, adrenal Addisonian crisis, which is severe symptomatic stage of adrenal insufficiency. It's caused by stress like trauma, infection, and surgery. Symptoms were severe hypotension, cardiovascular collapse, abdominal pain, acute renal failure, and death. Renal failure, abdominal pain, cardiovascular collapse, hypotension. Okay. IV hydrocortisone give 100 mg IV bolus. Maintain 100 mg IV for every 6 hours. IV fluids you give and taper the steroid gradually. Hydrocortisone, IV fluids, taper gradually. Severe hypotension, cardiovascular collapse, abdominal pain, renal failure, stress, trauma, surgery, infection. Okay, so this is the adrenal and all the hormones that it is secreting. And whatever it is dependent upon. Sonoglomerulosa, zonofasciculator, and zonoreticularis, androgens, and cortisol. Glomerulosa is aldosterone. So primary hyperaldosteronism is excessive production of aldosterone independent of renin-angiotensin system, characterized by hypertension, hypokalemia, and alkalosis in absence of diuretic administration. Essential criteria is diastolic hypertension without edema, hypersecretion of renin that fails to increase appropriately during volume depletion, hypersecretion of aldosterone that fails to decrease during volume re-expansion. So when volume depletes, decrease, renin doesn't increase. When volume increases, aldosterone does not decrease. That's it. That is the meaning of this. Aldosterone should decrease when volume increases, and renin should increase when volume decreases. So it is the primary diastolic hypertension without edema. So it is caused by aldosterone producing adrenal adenoma, Crohn's syndrome, hyperplasia of adrenal glands, idiopathic hyperaldosteronism, hyperaldosterone producing carcinoma. So clinical features here: hypertension, very much diastolic BP is more than 110. Hypokalemia, potassium level is very much less. Cramps, fatigue, polyuria, polydipsia, muscle weakness all occurs. Impaired glucose intolerance will be there, and metabolic alkalosis and edema investigation you have to perform. So investigations, you have serum potassium levels, plasma aldosterone, renin, angiotensin, and electrolytes, CT, MRI, renovenogram for tumoral localization. So management, you have Crohn's syndrome, will give surgery spironolactone for 4 weeks before surgery every day. Hyperplasia of adrenals, you give dexamethasone for 4 weeks. If BP remains high, you replace dexamethasone with spironolactone. Adrenalectomy is not indicated, only in Crohn's syndrome it is indicated. Then secondary hyperaldosteronism, 85%. Okay, it is due to excess of aldosterone with high renin levels. It is caused by adrenal artery stenosis, accelerated hypertension, and diuretics. Treatment is amiodarone, captopril, causes adrenal artery stenosis, accelerated hypertension, diuretics, hepatic failure, Bartter's syndrome, primary reninemia, congestive cardiac failure, nephrotic syndrome, primary renin secreting tumor, Litzman syndrome. So treatment of excessive aldosterone is amyloride, captopril, spironolactone to correct hypocalcemia, kalemia, hyperrenilemia, and hyperaldosteronism. Increase aldosterone, decrease potassium, potassium, and increased renin. Then moving on, pheochromocytoma, which is benign tumor arising from chromatin cells of sympathoadrenal system. There is a rule of 10. 10% is extraadrenal, 10% is malignant, 10% in children, 10% is bilateral, more on the right side, 10% not associated with hypertension. So clinical features, you have sustained diastolic hypertension, paroxysmal episodes of severe hypertension, severe pounding headache, sweating, tachycardia, palpitations, anxiety, feeling of impending doom. So diagnosis, you have 24 hours urine test, you have metanephrine, norepinephrine, vinyl malonic acid, and homovalenic acid. So laboratory findings, you have hyperglycemia, hyperlipidemia, hypokalemia, plasma metanephrin, tumor localizing tests also you can do, CT, MRI. Then treatment, you have surgical tumor resection with early ligation of venous drainage is the treatment of choice. Venous drainage you have to ligate, and surgical tumor you have to resect. Ligation prevents lowest possibility of catecholamine release and crisis. To control BP, you have to do alpha blockade. Phenoxybenzamine for 10 to 14 days prior to surgery. To decrease tachycardia, you do beta blockage. Propranolol for 2 to 3 days prior to surgery. Normal calcium in the serum is 8.6 to 10.3. Calcium regulation involves 3 tissues: bone, kidney, and intestine. 3 hormone: calcitonin, vitamin D, parathyroid hormone. So parathyroid glands, your function is to excrete extracellular fluid and calcium gland. Acts directly on bone and kidneys, acts indirectly on the intestine. The effect of synthesis of 1,25 dihydroxycholecalciferol. So effects is increased osteoclast activity, inhibits phosphate reabsorption in kidney tubule. So favoring buoyant dissociation release from bones, activates vitamin D and increases GI absorption of calcium. So osteoclasts are cells which break down bone to metabolite, which is it? Bone to blood. Phosphate reabsorption in kidney tubule, favoring bone dissociation and calcium replace. Inhibit phosphate reabsorption, activates vitamin D, causes GI absorption of calcium. So again, I just want to review entirety of everything. Insufficiency and all, mineralocorticoid insufficiency, hypotension, hyperkalemia, hyperpigmentation, hyperkalemia, primary aldosterone, not in secondary aldosterone. These are the symptoms. Hyper everything. Sodium will be less, neutrophils will be less, lymphocytes will be increased. Yes, fields will be more. Loss of body hair, loss of libido, vitiligo, partial hypertension, hyperpigmentation of the different parts of the mouth, pallor, anorexia, nausea, vomiting, diarrhea. So hypertension, vitiligo. Okay. Investigation: plasma electrolytes, decrease in sodium, increase in potassium, increase in calcium. and decrease in glucose. 2 will be increased, 2 will be decreased. Okay. Stimulation test you have, meperidine test you have, hydroxy in fall in cortisol. 11b hydroxylase fall in cortisol. Rise in ACTH. Rise in 11 dihydroxy cortisol. Okay. Single dose. Okay. Plasma renin activity. I is primary insufficiency. Low is secondary insufficiency. Plasma aldosterone is low. Plasma aldosterone level is normal. Fluorocortisone, mineralocorticoid. Okay. Glucocorticoid. You give prednisolone, hydrocortisone, cortisone acetate. So secondary adrenal insufficiency, glucocorticoid daily and mineralocorticoid replacement is not necessary. Taper the steroid gradually. Obese patients of increased dose and those people, steroid doses. Okay. Adrenal crisis, acute severe treatment. You give hydrocortisone 100 mg every 6 hourly and IV bolus first. Then you give IV fluids and taper the corticosteroids. Severe hypotension, cardiovascular collapse, abdominal pain, renal failure, and death. Okay. Hypertension without edema. Primary hyperaldosteronism is aldosterone independent of renin-angiotensin system. You have hypertension, hypokalemia, necrosis, absence of diuretic administration. Okay. Diastolic hypertension without edema, hyposecretion of renin is low, it will not increase. If volume is decreasing, renin will not increase. If volume is decreased and aldosterone is high, it will not decrease. Yeah. Crohn syndrome is there, hyperplasia of adrenal glands, idiopathic hyperaldosteronism, aldosterone producing carcinoma. Impaired glucose tolerance, metabolic alkalosis, edema, investigations. Okay. So sodium potassium levels you have to do. Serum potassium levels you have to do. Serum potassium levels, serum aldosterone, renin, angiotensin, and electrolytes. CT, MRI, renal venogram for tumor localization. So for management, you have Crohn's syndrome, surgery, spironolactone you have to give. Hyperplasia, you can give dexamethasone. If BP still remains high, dexamethasone with spironolactone. That's it. Secondary hypoaldosteronism is aldosteronism with high renin levels. So it is due to renal aldosterosis, accelerated hypertension, diuretics, hepatic failure, beta syndrome, congestive cardiac failure, floating syndrome, primary renin secreting tumor, and Glitzman syndrome. Treatment is amiodarone, captopril, spironolactone. All are potassium sparing diuretic. Hypokalemia you have to treat, hyperkalemia and hyperaldosteronism you have to treat. Hypokalemia is there, hypertension is there, impaired glucose tolerance is there, metabolic alkalosis is there, edema will be there. Hyperchromosydoma, hypercalcemia, hypocalcemia, hyperparathyroidism, acromegaly. That's all the topics. Once I'm finished with this, I can go on to cardiovascular system and nutrition. Those are the only two topics. Okay, so pheochromocytoma is a benign tumor arising from chromaffin cell for sympathetic adrenal system. There is rule of 10. 10% is extrarenal, 10% is malignant, 10% in children, 10% is bilateral, and 10% not associated with hypertension. So clinical features, you have sustained diastolic hypertension is there, paroxysmal episodes of severe hypertension is there, severe pounding headache is there, sweating, tachycardia, palpitation, anxiety, feeling of impending doom. So 24 hours urine test, metanephrine, vinyl acid, normetanephrine, homovalenic acid, vinyl acid, homovalenic acid. Laboratory finding, you will find hyperglycemia, hypokalemia, hyperlipidemia, plasma metanephrosis will be there, tumor localization, CT MRI. Sustained diastolic hypertension, paroxysmal episode of severe paroxysmal during the night, episodes of severe hypertension, pounding headache, sweating, tachycardia, palpitation, anxiety. So bilateral, extrarenal, by 10% malignant, 10% bilateral, 10% extrarenal, extraadrenal, 10% in children, and 10% not associated with hypertension. It is rule of 10. Treatment: tumor resection with early ligation of venous drainage. Ligation lowers the possibility of catecholamine release or crisis. Control the BP, you give alpha blockage, phenoxybenzamine for 10 to 14 days prior to surgery. To decrease the tachycardia, you give beta blockage, propranolone for 2 to 3 days prior to surgery. Phenoxybarbital, propranolone. So normal sodium calcium serum is 8.6 to 10.3 mg per deciliter. Calcium regulation involves 3 tissues and 3 hormones: parathyroid hormone, calcitonin, vitamin D. Parathyroid gland is to maintain extracellular fluid concentration and export one on kidney indirectly on kidneys. Interesting. Okay, fine. Let's finish hypercalcemia, hyperparathyroidism, hyperacromegaly, and we are done. No, we have to finish mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and we are done. After the cardiac fibrillation, then vitamin A, vitamin B, vitamin C, vitamin D, vitamin E, vitamin F, K. After that, obesity, and I'm done. After that, fluids and poisoning. Again, after device poisoning. Genuinely fucked, man. Fine. Hypercalcemia is caused by increased release of calcium in bone, primary hyperparathyroidism, tertiary hyperparathyroidism, malignancy, thyrotoxicosis, vitamin A intoxication, and package disease of the bone. Increased absorption from intestine, hypervitaminosis, vitamin D, sarcoidosis, decreased renal calcium excretion, familiar calciuria, milk alkali syndrome, acute renal failure, decreased uptake of calcium by bone, aluminum toxicity, pseudohypercalcemia, microglobulinemia, myeloma, hyperalbuminuria. Anemia. So drugs, you have thiazide, diuretics, estrogen, and tamoxifen. Diagnosis, you have serum level, PTH, calcium, potassium, Cl by chlorine by potassium ratio will be decreased, which is diagnostic. ECG will be showing shortened QT interval. Urinary calcium excretion is a bone scan you can do. Localization by ultrasound, CT, MRI, and parathyroid angiography you can do. Parathyroid hormone levels, calcium levels, potassium levels, chlorine by potassium levels will be decreased, which is diagnostic. Drugs you have thiazide diuretics, estrogen, tamoxifen. All of these cause hypercalcemia. Aluminum toxicity, pseudo hypercalcemia, macroglobulinemia, decreased renal calcium excretion. Then clinical features, you have stones, which is nephrolithiasis, bones, bone ache and pain, osteitis fibrosa cystica, pathological fracture, grunts and groan, you have muscle pain and weakness, pancreatitis, peptic ulcer disease, constipation, psychiatric fatigue and depression, anorexia, sleep disturbance and anxiety. Other findings, you'll find polydipsia, polyuria, nephrogenic diabetes insipidus, hypertension and weight loss. So treatment, you have increased urinary excretion, you give furosemide, which inhibits calcium reabsorption. You inhibit bone reabsorption in osteoclastic disease, bisphosphonates by calcitonin, and hemodialysis in case of renal failure patients. Renal failure, you give hemodialysis. Increase urinary excretion, you give furosemide, which inhibits calcium reabsorption. Inhibit bone reabsorption in osteoclastic disease by giving bisphosphonates and calcitonin. So hypocalcemia, it is caused by hypoparathyroidism. Most common cause, renal insufficiency due to decreased vitamin D, vitamin D deficiency, hyperphosphatemia, hypomagnesium, which decreases parathyroid hormone secretion, pseudo hypoparathyroidism, parathyroidism, acute pancreatitis, blood transfusion, citrated blood transfusion, calcium binds to citrate, and osteoblastic metastasis. So clinical features, you have rickets and osteomyelitis. Numbness and tingling is there. Tetany, you have hyperactive deep tendon reflexes will be there. Chokstovic sign, which is tapping facial muscle, leads to twitching of facial muscles. Trossau sign, inflate BP cuff higher than systolic BP for 3 minutes, leads to carpopedal spasm. Basal ganglia calcification is there, and cardiac arrhythmia is seen. So diagnosis, you have serum level, PTH, calcium, potassium, you have to check. Prolonged QT interval will be there. Urinary calcium excretion, bone scan, localization, same thing. Diagnosis, treatment, you have IV calcium gluconate, oral calcium carbonate and vitamin D. There is a diuretics to lower the urinary calcium and correct hypomagnesemia. This is for hypercalcemia. Hyper is inhibit calcium reabsorption, furosemide, bisphosphonates and calcitonin you give, decreases the calcium. Hemodialysis, renal failures. Here investigation is same for both of them. Prolonged QT interval in hypocalcemia, and urinary calcium excretion will be you have to check bone scan, localization, parathyroid, and geography is excessive in here. Primary hyperparathyroidism, hypoparathyroidism, renal insufficiency, vitamin D deficiency, hypervitaminosis of vitamin D, aluminum toxicity, pancreatitis. Okay. IV calcium gluconate will increase the calcium. Oral calcium carbonate and vitamin D. Thiazide diuretics lowers the urinary calcium, correct hypomagnesemia. That's all that is. Then hyperparathyroidism, you have primary hyperparathyroidism and secondary hyperparathyroidism. Okay, only one more page left. After this, mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. After that, infective endocarditis, I'll just do off, and nutrition I'll do off. So, primary hyperparathyroidism, adenoma, hyperplasia, and carcinoma. Clinical features: stones you have, nephrolithiasis, bones, bone ache and pain, osteotic fibroma, cystic pathological fracture, grunts and bone. You have muscle pain and weakness, pancreatitis, peptic ulcer disease, constipation, psychiatric overtones, depression, fatigue, anorexia, sleep disturbance, and anxiety. Other findings are polydipsia, polyuria, nephrogenic diabetes insipidus, hypertension, and weight loss. So, diagnosis: you give hypercalcemia, albumin levels, parathyroid hormone levels, hypophosphatemia, hypercalcemia, urine cyclic AMP will be elevated, chloride by phosphorus more than 33, X-ray bone reabsorption will be there. Treatment: you give furosemide, which enhances calcium excretion, and surgical removal, which is a definitive. Secondary is caused by renal failure or GI malabsorption, vitamin D deficiency. Pathogenesis: excessive calcium loss leads to compensatory increased production of parathyroid hormone. Treatment is treat the underlying cause. Tertiary hyperparathyroidism prolongs secondary hyperparathyroidism. Glands become autonomous and serum calcium level raises secondary to increase parathyroid hormone secretion. So, primary serum calcium is raised, parathyroid is not suppressed. Secondary serum calcium is low and parathyroid hormone is raised. Tertiary serum calcium is raised, parathyroid hormone is not suppressed. Raised low, low raised, raised low. Serum calcium is raised, but secondary is low because it is caused by renal failure and GI malabsorption and vitamin D deficiency. Excessive calcium loss compensatory increased production of parathyroid hormone. Treatment is treating the underlying cause. Glands become autonomous. Serum calcium level raises secondary to increase parathyroid hormone secretion. Here it is adenoma, hyperplasia, carcinoma. All of those will cause the increased parathyroid. Okay, so acromegaly, which is excessive secretion of growth hormone after epiphyseal closure. Etiology: growth hormone secreting pituitary adenoma. So signs: you have increased growth, metabolic and paracellular manifestation. So increased growth is soft tissue and skeletal overgrowth, coarse facial features, abnormally large head, organomegaly, hypertrophic cardiomegaly, and enlarged jaw. Metabolic diabetes mellitus, hyperhidrosis, not sure what that is. Paracellular is headache, optic chiasma compression, bilateral hemianopia, bitemporal hemianopsia, cavernous sinus compression will be there, and sphenoid sinus invasion will be there. So for diagnosis, you have IGF-1, which is also known as somatomedin C, is elevated in acromegaly. You have oral glucose suppression test. Glucose load fails to suppress the growth hormone as it should in normal individual, and MRI of the pituitary you have to do. IGF-1, somatomedin C, elevated in acromegaly. Okay, so treatment: you have transsphenoidal resection of pituitary adenoma is a treatment of choice. Radiation therapy, you have octreotide, which is somatostatin analog, suppresses the growth hormone secretion, and hypertonic saline inhalation. Radiation therapy, transnodal resection of pituitary adenoma. You go from sphenoid cavity to the pituitary adenoma and treat. Radiation therapy, octreotide, suppresses the growth hormone, and hypertonic saline inhalation. And again, we are done with major topics. The irritating this part. I have to do this, and after this I have to do dyslipidemia and nutrition. God damn it, man. I really do not want to do this. I want to do nutrition. That's Paka. And I want to do infective endocarditis and rheumatic heart fever criteria. It is Paka. But I do not want to do mitral stenosis and stuff like that. Just zero mood, man. So severity is according to all area and symptoms. Less than 1, less than 1. Okay. None dyspnea, PND with peripheral edema, orthopnea. Less than 1 centimeter, 1.5. 1.5 PND, dyspnea, and asymptomatic is found before symptom. Causes is rheumatic heart disease, parachute metal wall, Huntington's. That's all. More than enough. Let's keep amyloidosis, carcinoid syndrome. Okay. Symptoms: dyspnea, palpitation, fatigue, hemoptysis, recurrent bronchitis. Recurrent bronchitis is the main thing. So signs here: mitral phases, malar flush. Malar flush is attenuating cheek with slight telangiectasia, seen in pulmonary stenosis. ASD, carcinoid syndrome. You have small Olympus, loud S1, palpable S1, palpable S2. Left parasternal heave. Diastolic lower mitral area, opening snap will be there, diastolic murmur will be there, over apex with belly in the left position, left lateral position in exhalation, mid diastolic murmur, M, D, M, that's it. Diastolic 3, opening snap. Upon development of pulmonary hypertension, ASM heard over the pulmonary area, PSM which is increases on respiration heard along with left sternal border, which is functional TR, tricuspid regurgitation. Pansystolic murmur, early systolic murmur over the pulmonary area. Pansystolic murmur increases on inspiration, heard along left sternal border, functional tricuspid regurgitation. Mid-systolic murmur increases on exercise. Murmur disappears in severe due to decreased cardiac output. Cardiac output will decrease, murmur decreases and disappears. Opening snap will be there, diastolic 3 will be there, loud S1, palpable S1, palpable S2. Left parasternal leaf, left lower malar flush, and bronchiectasis. Complications: you have hemoptysis, sudden rise in left atrial pressure leads to pulmonary apoplexy due to rupture of bronchopulmonary vein, chest pain, atrial fibrillation, pulmonary edema, infective endocarditis, pressure symptoms. You have compression of left recurrent laminal nerve by enlarged left atrium, hoarseness of voice will be there, Ortner syndrome, and pressure on left main bronchus leads to bronchiectasis, and erosion of spine is paraplegia. You have left atrial myxedema, cotrema atrium may be there, ball valve thrombus of the left atrium is common, and mid-systolic murmurs along mitral valve as in ventricular septal defect, patent rectus arterius, severe mitral regurgitation, Tericom's murmur in mitral valvulitis. Recuspid also masks features of mitral stenosis and nostril flint murmur of aortic regurgitation. ECG, P mitral will be there, and right ventricular hypertrophy will be there. Atrial fibrillation, absent VVS, and varying RR intervals. Chest X-ray, you have left atrial enlargement, splayed cornea, straightening of the left heart border due to prominent pulmonary artery and left ventricular appendages, mitral valve calcification, curly B lines, curly A lines, pulmonary hemocytosis, parenchymal ossification due to pulmonary hypertension. Barium swallow, barium filled esophagus due to compressibility by compression by enlarged left atrium. Echocardiogram, thickened immobile cusp, reduced filtering, reduced valve area. Mitral stenosis. 4 to 6 centimeter normal mitral valve area is there. More than 25 is known. Cardiac catheterization, pressure gradient will be there, and cardiac angiography. So management: rheumatic heart fever, infective endocarditis, anticoagulation, treatment of AFib, closed mitral valvectomy, open valvectomy, percutaneous balloon valvuloplasty, and mitral valve replacement. That's it. Okay, 2 more pages and then only nutrition and infective endocarditis. Okay. Michael regurgitation, rheumatic heart fever, congenital metal, parasite metal prolapse syndrome, infective endocarditis, or infective rupture, cardiomyopathy, connective tissue uncoalescing, rheumatoid arthritis, amyloidosis, sarcoidosis. Symptoms have dyspnea, fatigue, palpitation, complication, atrial fibrillation may result in thromboembolism, infective endocarditis. Thromboembolism, infective endocarditis. Wide pulse pressure, soft S1, S3 over the apex, P2 is loud. Soft S1, whereas S1 was loud there. S2 is wide splitting S1, metal increased by hand grip, systolic thrill over the metal area, diastolic thrill was there, pansystolic murmur is there also, diastolic metal regurgitation, acute aortic regurgitation, left ventricular rapidly increases, resulting in regurgitation of blood into the left atrium. Here sections P mitral will be there. Here also left ventricular enlargement, whereas it was left atrial enlargement, atrial fibrillation was there. Okay, chest X-ray, cardiomegaly, calcification of leaflets and pulmonary hypertension, pulmonary edema, echocardiogram, dilated left atrium, regurgitation undetectable in echocardiogram, and cardiac catheterization. Pressure differences was there previously. Here they have not mentioned anything. Medical, you have ACE inhibitor, nitroprusside you have to give. Reduce afterload, reduce regurgitation. Surgical, you have valve replacement. So you have pansystolic murmur, PSM. MDM, OS, S1 increased, P2 increased. That's it. S1 soft and P1 increased, no? P2 increased. P2. Okay. Prolapse, I'm not studying aortic stenosis, aortic regurgitation. Okay. Causes, you have congenital, supravalvular, valvular, subvalvular, rheumatic artery stenosis, degenerative calcific, atherosclerotic. Symptoms: angina, dyspnea, syncope, and dizziness, and death due to complete heart block. Complication: left ventricular failure, arrhythmias, complete heart block, infective endocarditis. Ventricular failure, arrhythmias, complete heart block, infective endocarditis. Signs: slow rising, small volume pulse, heaving apex beat, S4, ejection click. Ejection click and ejection diastolic murmur, ESM. Pansystolic murmur, pansystolic murmur, mid diastolic murmur, pansystolic murmur. Ejection system murmur radiated into carotids. So severity you have according to S2, A2 S2, delayed A2, reverse splitting, P2 A2, single S2, A2 P2 will be there in mild, only A2 will be there, and reverse splitting P2 A2 will be there in severe. Okay, then ECG, you have LBVB, left bundle block, branch block, and left ventricular hyperplasia with strain pattern. And you can have complete heart block complication. So chest X-ray, post-stenotic dilatation of aortic valve in venous aortic stenosis, calcification of the aortic valve will be there. Echocardiogram will show a calcified valve and hypertrophied left ventricle. Cardiac catheterization, there will be a gradient between left ventricular aorta and coronary angiography you have to do. So medical measurement is rheumatic fever, infective endocarditis, nitroglycerin for angina pain relief, and surgical management, valve replacement. Same in all of them. Then it is A2, P2, A2, P2, A1, A2. see if I can get only this part. Yeah. Then aortic regurgitation, infective endocarditis, rheumatic heart fever. Both are same, na? Congenital bicuspid aortic wall, fenestration of atrial ventricle, heavy prolapse, enough inflammatory conditions and connective tissue disorders, osteogenesis. Okay. Symptoms here: dyspnea, palpitation, angina. Dyspnea, palpitation, angina. Syncopal, angina. Okay. Syncopal, dizziness, death. Okay. Signs of wide pulse pressure. Lighthouse sign will be there. Alternate flushing and blanching of forehead. Land of sign, change in papillary sign with respect to cardiac cycle not related to light. Becker's sign, which is renal artery pulsation. Muller sign, which is renal pulsation of uvula. Corringa sign, dancing carotid, locomotor maculae. All of these will be there. Collapsing or water hammer pulse. Pulses by Fredens. Taube sign, which will short harmonic special sound hurt over the tricuspid regurgitation if it's there. Rosier sign, Hill sign, usually member over the femoral artery. Diastolic member over femoral artery and compressed dystole. Pulsation of pulsation member is decrescendo member, left sternal, left sternal molar. Austrian flint member is low pitched mid diastolic member, rumble across mitral wall due to anterograde flow from left atrium, lateral flow from aorta. Similar to mitral services, add additional S1 and opening snap. Okay. Loud S1 and opening snap is there, but here it is not there. Indian. Left ventricular enlargement, QOS will be there. Chest X-ray, you have gross cardiomegaly, syphilitic aortic regurgitation, calcification of ascending aorta, rheumatic aortic regurgitation, calcification of aortic valve. Okay, 1 second. Classification is there, na? Listen, supravalvular, valvular, subvalvular. Okay. Echocardiogram, dilated left ventricle, hyperdynamic ventricle, dilated aortic root, fluttering aortic anterior mislead, and cardiac catheterization. Medical regimen, prophylaxis, vasodilators, penicillin, syphilitic, and valve replacement. This is end diastolic member. This is systolic member, pansystolic member, mid diastolic member. Systolic 3, diastolic 3. Mm, okay. So yeah, I've been doing this for 2 hours now. Another hour and I can finish off everything. Vitamins is left, and infective endocarditis and rheumatic fever, atrial flutter is left. Let's just do it off. I think so. Mm, mm, mm. I have opened this. Okay, so infective endocarditis. Uh, not ischemic disease. Just before this. Mm, mm. Mm. Acute rheumatic fever, infective endocarditis, nutrition. Now I'm going to stop this and I'm going to sleep for a bit. I'll wake up around 8:30ish and I'll do it. Finish this. Okay.